All right, folks, this is going to be a very difficult to control podcast because here he is again. Papa is back in the saddle right here, coming with us from a location yet to be determined, someone like Porsche, but on the beach. As usual, Papa is never in an office when he talks to us on Healthcare Unfiltered. But thank God we have Dr. Loghavi with us, who's also another guest who's been with us before. So I'm very happy to host both of you on today's podcast. We're going to start by a little bit of an introduction, but just for listeners, as I said in my intro, really the purpose of this is to talk a little bit about the newest leukemia classification. And the purpose of it, we just want to try to understand how these classifications come about, why they occur, and the implication on diagnosis in clinical practice, research, as well as I'm curious to know, for example, what triggers investigators to decide to look at new classifications. All right, so we're going to get started. Sanam Loghavi, Dr. Loghavi, you start, introduce yourself, where you are, and welcome back to Healthcare Unfiltered. We're excited to have you.
Thank you so much, Chadi. So my name is Sanam Loghavi, and I'm a hematopathologist and a molecular pathologist at MD Anderson Cancer Center in Houston, Texas. And I'm very happy to be here.
You simplified pathology for us in the previous episode.
I did.
Papa, it's probably your fifth or sixth appearance, and despite every time you just mess things up, we still invite you back. I don't know why, but here you are. Introduce yourself. I know everybody knows you. I'm not sure there's a point of doing this, but
thanks for having me again. I'm calling from my porch in Pacific Beach, San Diego, California. It's about 70 degrees right now. It's nice. I'm a bone marrow transplanter, malignant hematologist at the University of California, San Diego, where we see all hematologic malignancies.
Okay, look, we're gonna get started. So my first question is, I don't want to talk about the newest classification yet. Take me back a couple of months ago, before this came about. Sanam, as a hematopathologist, what we're using at the time, and just take me through what triggers, like how long does it take to come up with new classification, and why do we need to reclassify things every so often?
Sure. I mean, so before the newest classification, the two classifications that are out right now, we were using the 4th edition of the WHO that was published in, it actually was, published as a paper in 2016, and that's why everybody calls it the 2016 WHO, but the book actually came out in 2017. So for those that are not aware, the WHO, the World Health Organization, has a series of blue books that essentially classify all sorts of malignancies. So every, organ system has its own blue book. So you have one for breast, you have one for GI, and so we had the heme. The heme book has always been the thickest one because, because of the nature of heme and because bone marrows and, lymph nodes are easier to access, there's a lot of molecular information. So, hematologic malignancies have always been ahead in terms of genetic classification compared to solid tumors. And so the book has always been a lot thicker and there's a lot more information in it. But, I think the reason that we come up with revised classifications is that we learn, right? We learn from research. And we have better tools to better classify these diseases. And I think, in fact, if you look at the 2016 WHO, it was actually a revised version. So it wasn't really a new classification. It was an update on the previous one because, so many things had changed in the hematologic malignancies world that they actually had to put out an update before the entire series was, republished or renewed.
Sanam, just really quick. So, but is it that the committee, who usually the WHO committee or the folks that did the 2016 classification, do they meet yearly and decide, is it time to look at another classification? Is there an actual cadence or a process, or is it somebody in 2022 is like, hey, it's been a while, let's get together, and take us through what happens?
Right. So there is a committee, right? And I think they do meet. So I'm not part of that committee. So I don't want to give any misleading information. But I think there is a committee. I don't think they decide annually to come out with, classifications. I think there's a timeline for the WHO. And again, that's why the fourth edition of the heme book kind of went out of order and was published ahead of the other ones because there was a need for a revised classification, but I don't think it was time to renew the entire series yet. And that's my understanding. I'm not sure if it's correct or not.
So as a lymphoma specialist, obviously we've been using the WHO Swerdlow et al. From 2016. Should we expect a new lymphoma classification coming up anytime soon?
Oh, there is. There's a lymphoma classification. The WHO is going to include a lymphoid, the WHO book is going to include both lymphoid and myeloid. And the ICC, there's now a blood lymphoma or lymphoid paper and a blood myeloid paper. So both classifications have revised lymphoma classifications as well.
Right, but are we expected, I guess, maybe I didn't clarify, are we expected the minute it comes out? Better rephrase the question. Is the expectation now the papers are out, overnight people need to switch? How they classify things?
When do you adopt it? I don't know. I guess that's a question for the clinicians in terms of how you would act on these. But I can tell you personally that myself now I'm going to start using the updated classification on my reports. And in fact, I think we're going to have a discussion among our group between the pathologists and the clinicians very soon, and review the new classification and its implications, for how we practice.
Aaron, you're a clinician, one of the smartest clinicians I have met over the past several years, and you're an educator, obviously. Before this classification came about, were you noticing some shortcomings? Like, were you as a clinician seeing patients and taking care of patients, were you thinking to yourself, they're missing something, I wish they come up with something that aligns with what I see? Were you identifying clinical gaps in the old classification?
Yeah, well, before I answer that, I just want to, my view on classifications of hematologic malignancies, right, these are just cells in various stages of maturation, differentiation, and we arbitrarily as humans draw these lines for these diseases, whether it's MDS, with the excess blasts, or AML, or especially with lymphomas, whether it's a mantle cell lymphoma or a marginal versus whatever we call it. And the cells don't know that. We just have to make these divisions. And why do we make these divisions? At least as a clinician, I hope that my pathology colleagues, when they come together and meet and go over if they need to make new entities or revise new entities, it's because of one of two things. There's a prognostic implication for the patient, or and which is where we're going with these classifications. There's a treatment implication, meaning something I can act upon. It makes no use to artificially divide acute myeloid leukemia into 10,000 different subtypes off every mutation if there's no prognostic or if there's no treatment implication. So and I think that is one of the reasons why I was drawn into our field, and I love pathology of hematologic malignancies. I think they keep that in mind, and as we learn more, we learn if you think about the diagnoses and how they classify, it kind of helps you with treatment and prognosis. So that's kind of my view as a clinician about why we need this, right? Why do we need to keep on revising this? And I hope when they meet in these groups, that's what they discuss also, which I suspect they do. So to answer your question, deficiencies, and we're just going to talk about myeloid, I believe, on this discussion. I think, and this isn't, I'm not the first to realize this deficiency, nor will I take credit. The artificial line in the sand of acute myeloid leukemia versus high-grade myelodysplastic syndrome. 20% more blasts will give you a diagnosis of AML, but if you're 19% blasts, without AML specific defining mutations, you're considered MDS. And it actually now does have treatment implications. Someone with 19% versus 20, I'm probably going to treat the same, especially if they're older, not fit for intensive chemotherapy with venetoclax azacitidine. But for insurance approvals, if it's called MDS, venetoclax isn't approved for that indication. So that's just one example that I can come off the top of my head.
So to summarize, just because, as you know, some of our listeners are a little bit general audience, not always hematopathologists. What you're contesting is, in the old classification, there was an arbitrary number that was chosen, above which a disease is classified as acute myeloid leukemia, below which the disease classified as myelodysplasia. Sanam, how did this number come about? Like, you just like flip a coin, 20, 25?
No, so if you go back to the FAB classification, I don't know if you remember the French, American, British classification. So the AML cutoff.
I'm old. I do.
I'm actually a big fan of the FAB, even though, you know,
Actually, it was the easiest.
So
for me, it was the easiest.
So, you know, we had the RAB-T category, right, which was the refractory anemia with excess blast and transformation. And that was the 20 to 30%. And then 30% and above was AML. So, you know, there are studies that actually, again, you know, I with acknowledging that the blast count is not very reproducible and also an arbitrary number. But, you know, high blast count AML versus low blast count AML, there are historical papers that, you know, show significance. But I think if you think about it, at the time when we came up, we as a field, not me, right? When the field of hematopathology came up with these numbers, we didn't really know much about the genetics of AML, except for maybe some of the translocations, right? Some of the chromosomal abnormalities. Remember, mutations, as we know them now, only started being incorporated into the diagnostic or prognostic algorithms, maybe like in the last 10, 15 years, right? So I think that was the best we could do at that time, to come up with something that would differentiate between MDS or low risk MDS cases and maybe the higher risk MDS cases and then AMLs, right? But now we know that there are certain genetic abnormalities that, regardless of blast count, probably dictate the course of the disease that is more closer to AML. And then others may behave like a low risk, well, it's not true. If you have high blast count, you're not going to behave like a low risk MDS. But, some AMLs with good genetics may actually behave better than some MDS with bad genetics, right? So I think the blast count is now not as robust of a prognostic indicator as it used to be when we didn't have this information. And I think that's, and you'll see that both classifications now have modified the way that they look at blast counts.
Aaron, before the new classification, and we're going to go over that in a little bit, was there only one classification that you're using as a clinician, which was the WHO? From listening, did you have more than one classification you were using before the new thing?
So it's mainly for me, the WHO, which I have a copy of that book, and I would try to read most of that book, especially when I saw the diagnoses. And that's it's what my pathologists were using at the university I work at, and they were using the WHO.
So, okay, so let's go now over, obviously, we have progress in the field, and the pathologists got together and they felt it's time to do this. Are these two completely separate entities, Sanam, like two completely separate bodies that is there crosstalk between the WHO and the ICC? And the ICC stands for what, for those who don't know?
International Consensus Classification.
Okay.
So I'm not aware of a, systematic crosstalk between the two, but I do want to make 2 points, just to clarify in the beginning. One is that the classification is not made entirely by hematopathologists, right? So both the WHO and the ICC, if you look at the people that are, authors and advisors on the on both classifications, so it's a, it's pathologist, hematologist, oncologist, geneticists, molecular biologists, researchers. So there's, it's a very multidisciplinary system, both the WHO and the ICC. And the reason for this being that I think, it's everybody recognizes that it's essentially impossible to, practice and come up with classifications in a vacuum. You need input from multiple teams to come up with a, with a sound classification that is practical and, and people can actually apply it and treat patients. So that's one. The other point I want to make is that, both of these classifications are evidence-based, right? Nobody just sat and came up with disease entities because, they like to. So for the most part, there is a lot of overlap. If you actually read the two papers, there's a lot of similarities. I think where there are differences are subtle things. And again, are maybe, what Aaron was saying, are in the more arbitrary things, or criteria, and not necessarily the genetics or, the more objective criteria.
So I want to go over some of these similarities and differences. Aaron, as a clinician, and you are going to have to teach your residents and fellows and students who are going to come with you through the rotation about these new classifications. When you first saw these two, what struck you the most as a clinician educator?
Well, they're one, just looking, there's a lot of new stuff to know. And I've mainly looked at the WHO, which for the record, that's the one I'm going to adopt because I that's what I used before. But the MDS is completely revamped and different from what there's a lot new. There's now more genetic defining, AML events. Like, we always remember 1517, which is acute promyelocytic leukemia, 821 and version 16 are core binding factors. Those were ones that were defined by cytogenetic abnormalities. There's now new there's additional ones that we have to know that regardless of blast count will be called AML. Those were kind of the main things. Systemic mastocytosis, which is a disease I like because it's an oddball one that I see in my clinic, which is already incredibly confusing. They added some nice little nuances to that I'll have to pull out that algorithm and paste. So what surprised me was it's been a few years, and things are different, which is exciting. But it's also a little bit frustrating that I have to, I don't know them yet. And I'm seeing these diagnoses, like it's kind of scary. Like I'm seeing patients and I don't know the exact diagnostic criteria yet. I'm being honest with you. I don't think anyone really does yet. And I'll get comfortable with them. And then, which we'll talk about when she goes over some of the differences, that just adds a new little bit of layer of uneasiness for me and frustration. The fact that there's some differences between how we classify cancers in individuals.
But you did feel when you look at the WHO, you felt it added a little bit more granularity and clarity in terms of prognosis and treatment implications to your patients, or you?
Yeah, and I don't have it memorized. Sanam, hopefully she does, and we'll go over the. I like how the new MDS to me it's refined in a little bit simpler in a way, and the more genetic, like there's beautiful stuff now with TP53, which we've all known for quite some time that TP53 mutated myeloid neoplasms, whether it's MDS or AML, are very difficult diseases to treat. But there's been some confusion with regarding, do you need one TP53 mutation, two, how do you define that? And this was further refined in these classifications, which I like now. Now I can say with more comfortable that, when a patient's in front of me and has one of these truly horrific leukemias or MDSs, that it's a specific diagnosis and I can go over the prognosis with them.
So Sanam, we're going to focus, we can't cover everything, right? We're not going to, we can spend an entire episode on just systemic mastocytosis, but we're going to.
Oh, that would be a great episode. Sign me up. Yeah.
Yeah, I'll come back for that.
Probably will be seen by two people.
Two people, that's okay.
Yeah, but we've agreed before we went on the air, we're going to discuss AML and MDS specifically. So you'll have to admit, Sanam, that for clinicians, when you have two classifications, if they're consistent, it's fine, but clearly there are two because there are some differences. Let's start. What differences exist in MDS, and maybe a little bit of a quick explanation how things were before, so
right,
listening can get context.
So if we go to the prior WHO classification, really we used a 20% blast count for AML, and anything short of that was MDS, right? So you had low blast count MDS and then MDS with excess blasts. I think we spend a lot of time determining, as pathologists, is this MDS with unilineage dysplasia? Is it MDS with multilineage dysplasia? Because those were part of, subclassifications of MDS. Now, if you look at, I'll start with, I think what is the major difference between the two classification systems is the category of MDS/AML that exists in the ICC and does not exist in the WHO, right? So that's, I think, the major divide. And I think,
Sanam, can you clarify that? So it's MDS AML is its own entity, right?
MDS
distinct
AML
from MDS
is
and distinct from AML.
Yes. So let me start with the WHO, and then we'll go to the ICC and we'll compare. So for the WHO, now there are additional AML defining genetic. So, as Aaron was saying, we knew that PML-RARA was AML defining. And what we mean by that is it's regardless of the blast count, right? If you have 15% blast, but you have a 15-17 translocation with PML-RARA, you're still AML. You don't need the 20%. And that's in the old classification, right? Or a core binding factor leukemia with 821 or inversion 16. So the WHO has now added to this class of AML defining genes several other chromosomal entities, including inversion 3. I think inversion 3 is what is the most significant change for AML defining, and then NPM1 mutation for WHO is now AML defining, and then the anything other than these genetic abnormalities, there's like a nice table that tells you what exactly these genetic, like an MLL or a KMT2, formerly known as MLL, but now like KMT2A translocation is AML defining, even if you have 10% blast by WHO. So the genetic abnormalities are pretty much the same in the ICC as well, except for ICC, you need at least 10% blasts to call any of these entities AML, right? And this includes 1517 and 821 and inversion 16. And anything between 10 to 20 with these abnormalities is going to be MDS/AML. And I think the reason, I'll tell you what I think the reason behind both classifications is for having or not having the categories. I think for the ICC, for having the MDS AML category, the intent was to give the clinicians the option to treat the patient as MDS or as AML as they see fit, right? So they can choose to treat the patient like MDS if they think the patient, is clinically behaving more like an MDS, or an AML if they think the patient is behaving like an AML. I think the reason for WHO for, essentially getting rid of the blast count is that, if you look at the majority of cases with these genetic changes, like with an NPM1 mutation or with an MLL translocation, these are very proliferative diseases. And, there are studies that have shown that these patients, if you leave them untreated for a couple of weeks, they're, if you leave, like I've seen this with my own eyes. You get an NPM1 mutated MDS, what's called MDS. We're a referral center. Patients come, from elsewhere. So they got a bone marrow biopsy last week. They had an NPM1 mutation and 5% blast. It was called MDS, rightfully by the previous classification. By the time they get to us, they have 70% blasts, right? So I think that is the reason. But again, the WHO does clearly acknowledge that, the boundary is not very clear. And, if the pathologist feels more comfortable, they can use the MDS/AML category.
So that's to comment on this. That does, to me, it doesn't seem there's a difference there, right? Because Aaron, even earlier you were mentioning, 19, 20%, I'm going to actually see how the patient looks. I mean, it seems like there's consistency, no?
Yeah, I mean, that's what I'm saying. I think, again, the logic is the same. And I think the science behind it is the same, right? These two systems use the same literature to come up with these classifications. I think that the wording is a little bit different, but I do acknowledge, and I think this is something important for us pathologists to be aware of, is that, the diagnosis that we make, we sign the report and then we're pretty much done with the diagnosis, right? But I think it has several implications. And I think we need to be, as a field, and, as clinicians, as pathologists, as, anyone that takes care of patients, we need to be aware of these subtleties. One is that, the implications for the patients, right? They want to understand their diagnosis. And I think that's very important because the patients have a right to understand their diagnosis and hopefully have a uniform diagnosis. So I think, for us to explain, maybe at least in our reports, and say this is this by one classification system and the other by another classification system, so that when the patient gets maybe 2 pathology reports from 2 different centers, they don't think that they have a conflict in their diagnosis. That is important. The other thing is, we have to think about the insurance implications of the diagnoses that we make, right? The eligibility of patients for trials. And I think this is very important for prospectively people that design clinical trials, right? So if you want to capture patients by both classification systems, I think you need to be aware that some of these patients are going to be called MDS/AML, others are going to be called AML. So when you're writing your eligibility criteria, you want to try and be more inclusive, right? If that's what the intent of your trial is, to be able to treat more patients. And these are things that I think we have to be proactively and prospectively aware as a field with the new classifications.
Aaron, I totally understand all of the point. I mean, Sanam articulated this wonderfully. I still see this is more similarity and kind of leaving things up to you as a clinician. If you see somebody with a 15% blast and you're looking at the chromosomal translocations, it gives you that more of your decision how you classify this. What are your thoughts as a clinician when you heard what Sanam said? How do you react to that?
Well, that's the shame of it all. They are very similar. There's based off the same data and the same good people. But, here's the irritation, or the irritating factor is, they come to me and they get a diagnosis by the WHO of AML, and then they go get their second opinion at the lovely MD Anderson, and the pathology report says something different. It's for no good reason, because we can't agree on one freaking classification system. It's just going to create an extra layer of confusion and possibly angst for the patients. As a clinician, I'm not going to present them both diagnoses. I'm going to say, this is what you got, and here's why I'm treating you, and so and so. And it's not going to be every patient, but it just adds to confusion and make patients uncomfortable.
But Aaron, I'll push back. I mean, as a clinician, you're still going to be held hostage to the report coming from your own hematopathologist.
At least it's one diagnosis. But furthermore, with the clinical trials, I mean, that's a whole nother, on top of the eligibility criteria. Do they choose one? Do they choose both? Now, when we go back in the future, 10 years from now, we want to go look back at one specific, group of patients, and it's going to be that much harder if certain trials are using one, even though they're the same, but are grouping them slightly different. It just, don't you see that that's going to add a complexity level that doesn't, if we had a complete agreement, it makes no sense that we have to have 2 different groups that classify these malignancies. Although they're basically the same, they're slightly different. And now we have what is already a confusing thing, hematologic malignancies, more confusing for. That's the frustration I have.
And I think we need to go over additional differences, but the way I envision clinical trial design will be, and maybe I'm wrong, I think future clinical trials will actually include both. They will say eligible patients are those who are classified by WHO as such or ICC as such. I think you're going to have to include those, because frankly, you can't tell what institutions will adopt, and I doubt that every institution will issue a report with both classifications. At MD Anderson, maybe they'll do that. They maybe issue a report, WHO is this, ICC is that. I think so.
But can't we agree it's a shame that, like, you could be an institution where pathologists in the same group or whatever are going to be using different, like that? It's just that's, again, I know it's more complicated and there's all this history and all these things, but it's just like, and then in the future when, right, this is just the first revision, they started out pretty similar, but who's to say at every reiteration of these there's more string, and it just creates a mess, in my opinion, that was, I wish, not necessary.
Are there other differences, Sanam?
Yes. Again, going back to MDS now, there are subtle differences. So let's start with the WHO. So the WHO essentially got rid of the morphologic categories of dysplasia, saying, unilineage dysplasia, multilineage dysplasia, a lot of it because, dysplasia is kind of in the eye of the beholder, especially mild dysplasia is very difficult to determine. So MDS is now classified by the WHO either by genetics or by blast count, or there's one category of hypoplastic MDS, which Aaron, I'm sure knows very well in the WHO, that is not included in the ICC classification. So the reason it is included in the WHO classification is if you look at the patients with hypoplastic MDS, there is a lot of overlap between these patients and patients that have aplastic anemia. Some of the shared features, including having small PNH clones, and these patients typically respond better to immunosuppressive therapy. So that's why the WHO decided to keep hypoplastic MDS as an entity. So the other the genetically defined entities by WHO are MDS with isolated deletion 5q, because we've always known the implications of this. MDS with SF3B1 mutation, again, because SF3B1 mutation we know is a good prognostic change or genetic change, and also is associated with ring sideroblasts. And then MDS with biallelic TP53 loss. All right, so let's talk about that a little bit, because I think this deserves a discussion in and of itself. So the reason for this category, and both classifications include this, right? And have this as an entity. MDS, I think the WHO calls it multi-hit TP53, and the ICC calls it multi-hit TP53, and the WHO calls it biallelic loss. So if you think about the biology of TP53 for the listeners that may not be as familiar, so TP53 is a tumor suppressor gene, right? It's one of the most important genes in our body. It's the most commonly mutated gene across all malignancies. And essentially, there's a germline variant of TP53, pathogenic TP53 mutations that cause Lee-Fraumeni syndrome. And these are patients that have a genetic predisposition to cancer. But the majority of P53 mutations are actually somatic, meaning that they happen during the course of loss and it's not inherited. It's actually somatic. So your cells acquire this mutation or lose a copy, and then you get loss of TP53. So if you think about most tumor suppressor genes, in order for them to have the detrimental effect that they do, you have to lose both copies, right? Theoretically, one functional copy should be good enough. Whereas oncogenes, like MYC, you only need one bad copy, right? It'll do its bad thing. So the reason that both classifications now have this is that, I think last year, a couple of years ago, this landmark paper by Elsa Bernard and Ellie Papamanuel, they actually looked at a large series of MDS patients and showed that patients with one mutation in TP53 essentially behave like patients that don't have a TP53 mutation. So you need loss of both copies to have the very bad prognosis that is associated with, TP53. And that's why both classifications now include TP53 biallelic loss. Now, how can you get biallelic loss or multi-hit TP53? So you can have multiple mutations, and theoretically, it's inferred that when you have two mutations, they're in the two different alleles, just thinking about the biology of P53. Or you can have one mutation and deletion of the other copy by way of chromosomal deletion, right? Loss of the short arm of 17, chromosome 17. Or the other mechanism by which you can get loss of TP53 is copy neutral loss of TP53. And that is the hardest for us to determine, because that is not something that we routinely look at in clinical laboratories. So we look for mutations, we look at the karyotype, and we can do FISH to detect copy number loss. But there are specific methodologies that can detect copy neutral loss of heterozygosity, and that's not readily available or routinely done. So there are some things that you can use, as a surrogate. So if you have a TP53 mutation with a very high VAF or variant allele frequency, then you can kind of infer that the other copy is also lost, and you only have representation of the mutant allele. So that's the story with the MDS with biallelic loss or multi-hit TP53. And both classifications include this. Again, both classifications include SF3B1 and deletion 5q. And then the WHO, if outside of these genetic categories, then you're classified by blasts. So there's low blast MDS, and then there's MDS with increased blasts. And increased blasts are the same as they were before. So it's IB1 and IB2, and it's the 2% and 5% blast count, and the 5% and 10% blast count for blood and bone marrow, respectively. And then for ICC, again, if you have more than 10%, then they don't have the excess blast 2 category anymore. That is called MDS AML in the ICC classification.
Aaron, I can understand why, as a clinician, you're confused or you're seeing. I mean, I see there's a lot of information that Sanam just shared with us, and I could imagine it will take months until people adjust to it. And in all fairness, Sanam, what you do at MD Anderson is all hematopathology.
Oh, I agree.
Right?
Yes, absolutely.
I'm trying, and I think in a lot of large community sites, there's also hematopathology at this point because it's a completely very different field. I'm just imagining how this will cascade into the general medical community. Aaron, can you reflect on all what Sanam just shared in terms of the MDS specifically, and how would do you have a way to simplify this? Because you are like the Twitter master when it comes to simplifying things like in 280 characters. I can't picture you simplifying the classification in 280 characters, Papa.
No, I don't think I could do the TP53 in that many characters. I echo your, this is no dunk on the community. They have the hardest job in the world. They do everything. And even for me, it's taken me 5 years as an attending to finally feel kind of comfortable with the WHO 2016. And I just imagine these community centers where they do all pathology, and now they're just hit up with this. I feel their stress and with the difficulty, as far as I think with the TP53, at least what's most useful for me, and I love that explanation, because that always confused me, especially now with that new data that you really need 2. And the way I think about it is, an easy way for me is, and Sanam can correct me if I'm wrong, usually when they have 2, even if it's hard for you to figure out if they have 2 losses in TP53, those are almost universally associated with those horrific karyotypes where every number in the world. Yeah. Right, it would be almost impossible, incredibly unusual to have 2 losses of TP53 and the karyotype report come back normal, correct?
100% correct.
Yeah.
Yes,
so
absolutely.
I think,
that'd be very unusual.
And clinically, if you can't figure out if there's 1 or 2, if you have 1 TP53 and an NGS and every cytogenetic abnormality in the world on your karyotype, you're going to treat them the same. And I think that eliminates that one rare type that she was talking about that we can't really test for. And when it comes down to it, and I've changed my mind on this with truly bad TP53 complex karyotype, the worst of the worst. Unfortunately, these patients, with everything we do, don't do that well. But I find it hard to make, put patients through with those mutations, with a standard induction, at least, even if they're fit, given their outcomes are unfortunately dismal with everything we do, to put them through a month in the hospital with 7+3. So I do think it's helpful in that we're finally officially recognizing that. And I think, at least from a clinical standpoint, I'm now treating all those with Veneza. A more broader or philosophical question is, should we even be transplanting those patients and putting patients through the resources of transplant when just about, I think it's a 5%, if even, long-term survival with that procedure. So I just kind of just rambled, but I think what Sanam said about TP53 really is succinct and worth, I think, the most important thing now to recognize.
Okay. Other differences on the AML side?
Right. So other differences, again, these are subtle, and I can tell you why the differences exist and why in reality they're not that different. So if you remember, the WHO 4th edition had the provisional category of AML with biallelic CBPA mutation. Remember that category, Aaron? So
yes,
the reason for that is that, historically, the literature had shown that patients with acute myeloid leukemia with biallelic, meaning two copies, right? Two copies of their CEBPA gene mutated, they have better outcomes, better prognosis. Okay, so now fast forward to the newer literature. Most recently, I think in January of 2022, a huge German study. There was literature before that too. I don't want to disrespect the authors that, from the other papers, but I think the largest series that I've seen is the German paper that looked at 4,000 plus patients. And they actually saw that, it's not necessarily the biallelic CEBPA patients that do better. It's the ones that have in-frame mutations in the BZIP domain of CEBPA that do better, even if they have one mutation, right? So now both classifications recognize acute myeloid leukemia with in-frame mutations in the BZIP domain of CEBPA as an entity. Where there's a subtle difference is that I believe for ICC, for WHO, I'm sure that biallelic is still included, and I believe for ICC it is not. So it's only BZIP. Now you may think that's very different, but in reality it's not, because if you look at the majority, 90% of the patients with biallelic CEBPA mutations actually are the ones that have, mutations in the BZIP domain. So if you look at these patients, there are very odd, rare scenarios where there might actually be a difference. But if you look at the majority of the patients, they will fall into the same diagnostic category. So that is, yes.
Before we move from the CEBPA, I'd like, Aaron, any comments on that?
Yeah, so this is something where, like, you hear her talk about this, zip this, that, as a clinician, you can look, let this go past you. But like, this is like something that's incredibly actually clinically important that, that worries me that this might, like, I just learned about this and like, I try to keep up with everything.
He keeps texting me once a week. He's like, do a tweet on CEBPA. Yeah,
like
I promise.
And why I was so, this is so important to know is because, this slight change where, so traditionally, just to repeat CBPA alpha, what was on the board is you need to have two mutations to be considered ELN or good risk AML. And good risk AML are typically patients that achieve a 90% complete response to 7+3 chemo and do not need an allogeneic transplant. And with that approach, roughly 50 to 60% of patients will achieve long-term cure. And you would always look for two, and it was always on the test. If you just had one, those were not the good actors, and you would treat them more like intermediate risk AML, which in many centers is an allogeneic transplant, which is like the worst thing in the world you have to do to someone if you have to do it. So you always look for an excuse not to do it. Well, now there's this BZIP, and if you just have one and have this zip thing, they're good risk. And like, I didn't know that. And like, here, I'm someone that like does transplant, like, and these are why this stuff's so important.
But hold on.
Yeah.
Hold on.
Can I just say something? This provides an opportunity for me to say something.
Yeah, and I wanted to say something, but I don't know if this is pushing back or not. But what I'm saying is, I don't think today you should be ready to change your entire practice based on this. There is no data yet.
No, there is. Chadi, there is.
To change
so the
practice,
classification.
to change practice?
Yes.
It wouldn't have changed the recommendation. This is a huge thing.
Yes.
But my question is like, are you ready? Okay, tell me about that.
Because it's, so this is not something that, like the classifications just came up with. There is plenty of data behind this. Right. And that's when, that's, I think, when changes in classification are made is when there's, sufficient and firm data behind these changes. And I think that's the reason. It's not based on this paper or the two classifications. It's based on years of literature before that.
Yeah, I guess I'm going back to remember when we started, we said there are two reasons to change the classification, prognostic or therapeutic.
Yes.
So that is my lack of knowledge that we have already therapeutic implication, because sometimes you can have the presence of something or the absence of it might have a prognostic implication, which is good enough for designing clinical trial when you select risk population. I didn't realize that this particular question has immediate therapeutic implication.
One BZIP now, if you look at the data, you just do chemo and they don't, they're a good risk AML, and a good risk AML won't do a transplant. had they had one without the B-zip, they do worse. And like, this is a huge change, which is why when I was learning about this, I was like, oh my God, like we need to scream this from the
Yes,
roof.
Sanam, you need to have it. You need to have it.
I will. I promise.
I don't want to screw it up. It's very important.
I will. I promise. So, okay. I think, I want to make maybe two suggestions, and this is maybe more for my hempath colleagues that, hopefully are listening. I think, as you were saying, I think hempath is becoming increasingly difficult and complicated, right? And that's why majority of hospitals or centers have hematopathologists, and a lot of as Aaron was saying, I think people that do general pathology, like people that do general oncology, have the hardest job in the world. It's very difficult to be able to say. I mean, God knows I can't do it for sure. We're very privileged. We look at this tiny field of disease and we get good at it, right? So, but I think it's important to recognize that with all of these complexities, it's important to send these cases out, have a specialist maybe look at them, or at least to the centers where they can do a complete workup on the patient, the patients or the samples. So that is one thing, because again, there's so much detail in actually giving a complete diagnosis for now a patient with an acute myeloid leukemia, right? Acute myeloid leukemia is like 100 different diseases. It's not just one disease. And the other is, I think, reading these papers, there are subtleties in the papers that I think, I read and I realize why these subtleties are in there, because I imagine seeing a case where this is an implication, but I think it may not come through as clearly if you're not a hematopathologist, right? So I think it's important to maybe talk to your hematopathologist, have them come summarize the paper for you, have them give a talk on the revised classification. So I think, both the trainees and, the clinicians understand the subtleties of how this is going to change our practice and the way we write our reports.
I can see a lot of workshops happening. I want to look, I know we want to do a short and sweet. There's a lot of things going on. I think my last topic that I would really want to talk about, and then I'll let you go to your own lives, which is, one of the things I like about social media is I usually get the pulse of what's going on. My sense is it doesn't reflect the real world, frankly, but it gives you a sense of what is really going on. I could tell that there was a lot of anger about these two classifications, to be honest. There was a lot of tweets flying, lots of comments, and people really upset. Some people saying, well, it's okay. I mean, there was a lot of emotions.
Yeah, Shadi, it's hard to get pathologists to be angry too.
I was honestly, I was surprised by that, because there was a lot of,
they're acting like oncologists, not pathologists.
I think there was a lot of angst, to be honest. And in fact, that is what generated the idea of doing this podcast, because I was a little bit surprised by this. So I'll start by you, Aaron. Why do you think there was, well, first of all, is my observation correct? And if it's correct, why do you think there was a lot of angst about this?
Well, I was clueless. I didn't realize there was going to be two classification systems until all of a sudden I saw this. I mean, I can imagine that, the reason why there's two is because there's clearly some disagreements amongst people in the field, enough where they had to divide ways and do these separate, even though it's practically the same thing. I can't speak to how those disagreements, I would love to know, but that's clearly what's happening here, right? Why else would there be two things that are identical?
But why was there anger? I guess why was there was a sense that this was such a bad thing? Again, this may be my
we want to all be like, hematology is already a small world. Like you would think, in the most important, as an outsider making an observation in the lovely small world of hematopathology, you think that there would be enough friendship and agreement to have one classification of the cancers they treat, or diagnose. I can't really specify, that's why I think there must be some issues. I don't know if Sanam knows more. I don't know what you want to talk about it.
Do you think I'm overreading this, that there was some angst and anger a little bit on social media about this?
Well, okay, let me start by this. I think, Twitter is a very, very provocative place. People love to like create drama and,
Who does that? No one does that.
I'm not going to lie. I don't think it's great having two classification systems. But again, I think if you read, into the classification systems, they are not that different. So I think that's, that's one thing to be hopeful about. And then also, I think it's also important to realize that, classification systems are evolving systems, right? This is not going to be the last classification system. I'm sure that, there's going to be revised iterations of the WHO, revised iterations of the ICC, and who knows, maybe they'll merge together again.
What's going to happen? What's going to happen, I think, here's what these two classifications have generated. They have generated countless podium debates in many conferences to come. You will have one person saying WHO, one saying ICC, and you'll get votes and ARS, and it's going to be a meeting organizer dream come true for a pathologist. I think so.
What can I tell you? Like, we made this so you can invite us so we can. No,
I think that's what's going to happen.
Oh.
All right. Well,
no,
I think this was great. I'm gonna let you both with the final comments from each side. Sanam, I know we probably did not cover everything. We tried. I think this is just about high level thing. We probably should do one on lymphoid malignancies as well. But any last comments you want to tell listeners about the topic and so on?
Yeah, I mean, I think, I'm a very optimistic person. So I tend to look at things, glass half full. So I think maybe for the trainees or for, junior investigators, there is some opportunity in this, look at where the classifications differ and see if we can actually come up with data that can rectify the differences, right? We come up with objective data that can rectify the differences. To me, that's a step forward, and it's also an opportunity for us to learn, right? So we just keep looking, we keep making better classifications, and hopefully, help patients, because I think that, that is the ultimate goal. It doesn't matter if you're a diagnostician or if you're an oncologist treating a patient, really, you're in the business of helping patients. That is what you want to do. And so we need to figure out how to do that.
Aaron, last comments, and then you need to go to run on the beach.
Yes, as an educator, I mean, I have printed out the WHO, both the lymphoid and myeloid, and I'm reading through them, and I'm dead set on learning them so I can teach them. And I think I will just settle the debate. I will only tweet out WHO classification in my tweets, and I will be hopefully.
Make sure you both need to send me the links for both of them so we could put them in the podcast notes.
Yeah, just Google
for sure
it.
I will. So I believe I'm not sure, I apologize if I'm wrong, but I think that the blood paper, the ICC paper, is actually behind a paywall. So I think if anyone from
it
blood
is behind
is
a
listening
paywall.
to this, right, I think it would be good to make that open access and make it available to people, so that they can use and read, the ICC classification as well. And I think, for people like Aaron and myself, I think, we just have to do our best to educate people and, tweet and, maybe, I don't know, I'm probably going to start doing a tweet every day. Sure. I mean, yeah, we're happy to. Thank you so much for having us. I mean, I think this is a great opportunity to talk about this and hopefully open the doors of education.
Yeah, I mean, I think, in all fairness, it's a difficult topic to do on a podcast. There's a lot of nuances. It's also a difficult topic for general audience. And I think, to your point, Sanam, it's one of those things where I believe they will need some workshops for the general pathologist, for the community pathologist. And I think with time, there will be adoption. I do agree with Aaron, though. I believe institutions will adopt one or the other. I think clinical trials will be different. And I think when you design a clinical trial for MDS or AML, you will put in your inclusion criteria classification by this or by the other, because you don't.
Yeah, I mean, I can tell you that we have already done this for one trial that I was involved with. We were talking about.
You will have
discussing, how should we modify the wording so that we can be more inclusive.
You will have to. All right. Well, look, this was amazing. This was wonderful. It was short, sweet, and great. We are all hoping for this episode to go viral because I have two amazing colleagues and friends and educators. So thank you so much for coming on Healthcare Unfiltered.
Thank you for having us.